name is Simmer Sukdillan, and I'll be talking about a patient who underwent 2 endoscopic pancreatic necrostomies with 5 days of nasogastric saline lavages. So acute pancreatitis can be complicated by the formation of pancreatic pseudocysts. And for the management of pancreatic pseudocysts, current literature shows that there is similar efficacy for surgical versus endoscopic management, whereas nasocystic irrigation has come forefront as a possible third option in the management of pancreatic pseudocysts. So our case is about a 65-year-old male with a past medical history of hypertension, peripheral vascular disease. He was a former smoker, GERD, and congenital absence of the left kidney. He initially presented to the ER with epigastric abdominal pain and was found to have acute pancreatitis with a lipase above 20,000 and supportive findings on CT abdomen showing trace fluid around the pancreas. GI was consulted, and they recommended a MRI MRCP that showed peripancreatic stranding, but no evidence of pancreatic pseudocyst. So the patient was admitted to medicine. He was seen by infectious disease, started on cefepime and flagyl due to recurrent cyclical fevers. But because there was no other indication for surgical or interventional radiology intervention, the patient was discharged on 14 days of IV ertapenem and told to follow up outpatient for management. At time of outpatient follow-up, the patient had a repeat CT abdomen, which showed a large pseudocyst. Following that CT abdomen, he presented to the ER again 4 days later, now with the chief complaint of epigastric pain, leukocytosis, and a lipase in the thousands. A repeat MRCP was ordered that showed complex pancreatic pseudocyst with concern for hemorrhage or abscess formation. Because of this concern and because of compression of the bile duct, the patient then underwent endoscopic ultrasound-guided drainage of the pseudocyst with stent placement. Following this procedure, the patient was started on broad-spectrum carbapenems and fluconazole. Despite being on these broad-spectrum antimicrobials, he continued to have recurrent fevers. So then a repeat CT was ordered that showed extensive gas. He then underwent esophageal-gastroduodenoscopy with necrostomy with percutaneous cholecystostomy tube placement. Following the procedure, the patient did have clinical improvement, but he continued to have recurrent cyclical fevers due to the necrotic pancreatic tissue, so he underwent a second esophageal-gastroduodenoscopy with necrostomy. However, at this time of the second procedure, surgery placed a nasocystic drain to allow for continuous irrigation. Blood cultures came back positive. Blood cultures and cystic fluid samples came back positive for C. glabrata, C. albicans, C. tropicalis, and euphicalis. So the patient was continued on broad-spectrum antibiotics. Following the second procedure, his clinical course was a lot better. He didn't have cyclical fevers. His vital signs were stable. Labs continued to trend downwards. So after 5 days of nasocystic irrigation, he was discharged home with continuation of broad-spectrum antibiotics. So in this case shows how nasocystic irrigation can be incorporated into the management for patients with pancreatic pseudocysts.